Welcome to the deep dive. Today, we're really getting into occupational and environmental medicine.
Yeah, we've got a whole stack of material here.
We do stuff from Rapid Review Occupational and Environmental Medicine. Some, chest x-rays, CT scans, regulations on health surveillance.
Loads of info on workplace hazards, health conditions.
Exactly. And our mission really is to pull out the most crucial bits, the key insights from all this for you.
Right. We want to get beyond just the textbook definitions today.
Yeah, understand the real impact.
What it actually means in practice.
And just to get you thinking, did you know there's this specific pattern on a chest x-ray,
Oh, yeah.
mostly in the upper lungs, that can really point towards silicosis?
Ah, yes, that upper lobe predominance.
Or that Australia, surprisingly, has the highest rate of mesothelioma globally, even though they weren't a huge asbestos producer.
It's pretty stark, isn't it? We'll definitely unpack why.
Okay, let's dive in. Maybe start with the basics. Exposure limits.
Good place to start. They're fundamental. You hear these terms thrown around. PLL, STEL, TWA.
PLL, permissible exposure limit.
That's the one. Think of it as the absolute maximum level for a substance. It's the concentration most workers can be exposed to day in, day out over a working life without, expecting bad health effects based on what we know now.
Okay, the main ceiling. And TWA, time-weighted average.
Exactly. TWA looks at the average exposure over a typical 8-hour workday.
So levels can go up and down a bit.
Yeah, as long as the average over that 8 hours stays below the PL, it accounts for variations during the shift.
Got it. And the last one, settle, short-term.
Short-term exposure limit. Yep.
Okay.
This one's for shorter bursts of exposure, usually about 15 minutes.
Why have that separate limit?
Well, some substances can have pretty immediate nasty effects even with just brief high exposure. So the STEL protects against those acute effects. Even if your overall daily average, the TWA, is still okay.
Ah, I see. Like a safety net for spikes in exposure.
Precisely. And these concepts, they're really vital when we start talking about specific occupational lung diseases.
Yeah.
Like silicosis.
Silicosis, right, that upper lobe pattern you mentioned.
Yeah.
This is where the work history becomes so important, isn't it?
Absolutely critical. You need the details. What exactly were they doing?
Like, were they cutting stone, concrete, sanding?
Yeah. And crucially, was it dry cutting or wet cutting? Wet methods make a huge difference in keeping dust down.
Right. Less dust in the air.
And what about ventilation? Was it working properly? Even things like their rate of perceived exertion. How hard were they working? How heavily were they breathing?
So how much dust they might have actually inhaled.
Exactly. And of course, how long were they doing this? Weeks, years, decades. Plus, simple things like housekeeping. Was the place kept clean, or was dust allowed to build up everywhere?
It's not just if they were exposed, it's the whole picture.
It's the intensity, the duration, the controls, everything.
And if you do see signs of lung scarring, pulmonary fibrosis, silicosis is just one possibility, right?
Oh yeah, lots of things can cause fibrosis. But interestingly, where the fibrosis shows up in the lungs gives you big clues.
Like the upper versus lower lobes thing.
Exactly. For that upper lobe pattern, there's a handy mnemonic. SHART.
Sure does. Okay, what's that stand for?
Silicosis, sarcoidosis, coal-workers' pneumoconiosis, histiocytosis, ankylosing spondylitis, allergic bronchopulmonary aspergillosis, radiation, and tuberculosis.
Wow, quite a list. But useful.
It is. Helps narrow things down.
Wow.
Many of those involve granulomas, actually.
Interesting. And for the lower lobes?
For lower lobe predominance, think RASCO-R,
RASCO-R.
rheumatoid arthritis, asbestosis, scleroderma, cryptogenic fibrosing alveolitis, which is basically idiopathic pulmonary fibrosis, and then other.
Other covers? What?
Mostly drugs, actually. Things like busulfan, blumycin, nitrofurantoin, hydrolysine, methotrexate, amiodarone.
So knowing the location on imaging is really key for differential diagnosis.
It helps enormously.
Okay, let's look at those images then. Chest x-rays first. What does silicosis typically look like?
On a standard x-ray, you're looking for multiple, small, round, white spots nodules. Usually between 1 and 10 millimeters.
And mostly upper lobes, you said.
Mostly upper lobes, yeah. And often towards the back, the posterior portions, we've got that image labeled silicosis upper lobes. You can really see those little nodules clustered up top there.
Yeah, I see them. Quite distinct. And the diffuse one?
That shows it spread much more widely through both lungs, not just concentrated in the upper zones.
Okay. And then there's this progressive massive fibrosis x-ray. That looks much worse.
It is. That's complicated chronic silicosis. Those small nodules we saw, they start to merge together, forming larger masses, bigger than a centimeter across.
Wow.
That PMF image shows those big, dense areas. Sometimes they call it an angel wing appearance because of the shape. You can also see other changes, like areas that look more solid and some darker, probably emphysematous areas too.
And people with this stage would have symptoms.
Oh, definitely. Significant shortness of breath, usually a bad cough. And their lung function tests, the spirometry, would likely show problems either obstruction, restriction, or sometimes both.
So those little spots combine into big damaging masses. What about CT scans? Do they show more detail?
CTs are great, especially early on. They can pick up really small nodules, often arranged around the lungs, lymphatic drainage channels, paralymphatic distribution, they call it.
Okay.
You often see swollen lymph nodes in the center of the chest, the hilum and mediastinum. And sometimes, not always, but quite characteristically, these lymph nodes can calcify around the edges.
The eggshell calcification.
That's the term. Very descriptive. As things get worse, CT can show honeycombing little cystic air spaces and that sort of hazy ground glass look suggesting inflammation or fluid. The CT image we have shows that conglomerate fibrosis, the big masses, along with emphysema.
So CT gives a much finer picture, especially early changes and those lymph nodes. Now, you mentioned different types of silicosis. It's not all the same.
Not at all. It's really a spectrum. We classify it based on how long the exposure was, the size of the nodules, symptoms, and lung function.
Right. So what are the main types?
You've got simple chronic, complicated chronic, interstitial pulmonary fibrosis, accelerated, and acute.
Okay, simple chronic.
That's usually after more than 10 years of exposure. Nodules are small, less than 10 millimeters, and surprisingly, often no symptoms, normal lung function.
Really? Even with lung changes?
Yeah, the lungs have a lot of reserve.
Okay. Complicated chronic.
That's the PMF we saw. Also over 10 years exposure, but now you have those large masses, over 1 centimeter. Definitely symptoms like shortness of breath, cough, and abnormal lung function, obstructive or restrictive changes.
Got it. And interstitial pulmonary fibrosis.
Again, usually over 10 years exposure. Here, the pattern on imaging is more widespread, net-like scarring reticulonodular. Symptoms like shortness of breath and cough are common, and the lung function typically shows restriction, plus problems getting oxygen across into the blood, reduced diffusion capacity.
Okay. And the faster ones. Accelerated.
Accelerated silicosis develops quicker, maybe 5 to 10 years, usually from higher exposures. The nodules and masses progress rapidly, symptoms are worse, and lung function deteriorates fast, particularly FVC and FEV1.
And acute.
Acute silicosis is rare but nasty. Develops in under 5 years from really intense exposure. The lungs fill up with fluid, and protein looks like alveolar proteinosis on imaging. Severe shortness of breath, restriction, poor oxygen transfer.
Quite a range depending on the dose and time. Is there a specific limit for silica dust in the air that workplaces need to stick to?
Yes. The Workplace Exposure Standard, or WES, for respirable crystalline silica is currently set at 0.05 milligrams per cubic meter of air.
Averaged over.
Averaged over an 8-hour day. That's the TWA we talked about. It's the level aimed at preventing disease in most workers over a lifetime.
But individual sensitivity can vary, right?
Exactly. Which is why health monitoring is also key.
Right. Like in New South Wales, what health checks are required for silica-exposed workers?
In NSW, there are pretty clear requirements. An initial medical exam when they start, including spirometry and a baseline chest x-ray, then annual checkups with spirometry. Chest x-rays are also repeated periodically during exposure.
And who reads those x-rays?
That's important. They need to be classified using the International Labor Organization ILO system, and it has to be done by a qualified B reader.
A B reader.
Yeah, someone specifically trained and certified to read x-rays for tough diseases like silicosis and asbestosis, according to the ILO standards.
Yeah.
Ensures consistency.
Makes sense. Need that expertise. Okay, let's shift gears to asbestos, another major one. You mentioned Australia's high mesothelioma rate.
Yeah, highest in the world, tragically, a real legacy issue.
And there are different kinds of asbestos.
Broadly, yes. Serpentine asbestos, which is mainly chrysodyl or white asbestos. It has curly fibers. That was banned here in 2001.
Okay.
Then you have the amphibole types like chrysotylite or blue asbestos and amosite or brown asbestos. These have straight, needle-like fibers and are generally considered more hazardous. They were banned earlier.
So different types, but all dangerous.
Absolutely. The goal now is asbestos-free workplaces. And if you find it during renos or whatever, the strong preference is always for complete safe removal, not just trying to cover it up or seal it in encapsulation.
Removal's the way to go. What about the diseases it causes? Mesothelioma, lung cancer, asbestosis. They take a long time to show up, right?
Very long latency periods, yes. Mesothelioma, the cancer of the lung lining, Typically takes 35 to 40 years after first exposure to develop.
Decades. Wow.
Lung cancer related to asbestos usually has a latency of around 20 to 30 years. And smoking drastically increases the risk for asbestos-exposed workers.
A deadly combination.
Absolutely. And asbestosis, the scarring of the lung tissue itself, takes about 15 to 25 years.
So these diseases are often diagnosed long after the exposure has stopped.
Very often, yes. Which makes tracking and prevention so vital.
Is there an exposure limit for asbestos fibers, too?
Yes, the occupational exposure standard for airborne asbestos fibers is 0.1 fibers per milliliter of air as a TWA over 8 hours.
And what counts as a fiber for that measurement?
It's quite specific. They look for fibers that are respirable, meaning they can get deep into the lungs. So less than 3 micrometers wide, more than 5 micrometers long, and with a length-to-width ratio of at least 3 to 1.
Pretty precise definition. And you hear about friable versus bonded asbestos.
Yeah, that's a really important distinction for risk. Friable asbestos is material that can be easily crumbled or turned to powder by hand when it's dry. Think pipe lagging or insulation. That releases fibers very easily.
High risk.
Very high risk. Bonded asbestos is where the fibers are locked into a solid matrix, like in asbestos cement sheeting or vinyl floor tiles. It's much less likely to release fibers unless it's cut, drilled, sanded, or badly damaged. Still needs careful handling, but the immediate risk is lower if it's in good condition.
Okay, so friable is the really crumbly, easily airborne stuff. What should be in place to manage asbestos risk in a building? An asbestos management plan.
It's essential. Every workplace suspected of having asbestos needs one. It starts with identifying where it is a survey.
Find it first.
Then assess the risk. What type is it? What condition is it in? Is it likely to be disturbed? Maybe do some air monitoring.
Okay.
Then you need a plan for control. Ideally, removal, especially if it's friable or damaged. If not immediately feasible for stable stuff, then interim measures like encapsulation or enclosure might be used, but removal is the goal.
And keeping track.
Absolutely. An asbestos register listing all known locations and types, clear labeling, regular inspections, and crucially procedures for any work that might disturb it. Plus, training for staff, know the risks, know where it is, know the procedures. Consultation with workers is key too.
Sounds comprehensive. Needs to be.
It really does. And safe removal before any demolition or major renovation is non-negotiable.
Right. Now, what does asbestosis look like on imaging? Different from silicosis.
Often, yes. On X-ray, you might see irregular lines, a sort of fine net-like pattern, often more pronounced in the lower lung zones. Silicosis tends to favor the upper zones more.
Lower zones for asbestos, often.
Okay. And you might see pleural plaques, thickened areas on the lining of the lung. They could be calcified or not. These plaques are a strong indicator of past asbestos exposure, though they don't necessarily mean the person has asbestosis itself.
Ah, so plaques are a marker of exposure, not necessarily disease.
Exactly. CT scans are even better at showing early asbestosis changes in those lower peripheral lung zones, little dots, lines, thickening around airways, those curved lines under the pleura, and they show the coral plaques very clearly, like in that CT image we have.
Those plaques really stand out on the CT. Does the ILO classification system used for silicosis X-rays apply here too?
Yes, the ILO system is used for all the pneumoconiosis dust diseases. It's a standardized way to grade the profusion, size, and shape of small opacities seen on the X-ray, from category 0 up to 3, with subcategories. Provides consistency worldwide.
Good to have that standard. Okay, let's move to another big workplace issue. Noise and hearing loss. What are the different levels we talk about?
Hearing loss is measured in decibels, dB. Normal hearing is roughly about 10 to 15 dB. Then slight loss is 1625, mild is 2640, moderate is 4170, severe is 7190, and profound is anything over 91 dB.
So a clear scale. And the protection earplugs, earmuffs. Pros and cons.
Earplugs are generally cheaper, smaller, maybe more comfortable in heat. They can offer decent reduction, maybe 1524 dB if inserted correctly. That's the catch. Compliance and fit really matter.
Right, if they're not in properly.
They don't do much. Earmuffs usually give more reduction, say 2033 dB. Easier to put on, maybe better for intermittent noise where you need to communicate. But they're bulkier, can be hot, more expensive, and fit can be affected by glasses or hair.
Trade-offs for both. Are there classes of protection based on noise level?
Yes. Hearing protectors are classed from 1 to 5. Class 1 is for lower noise, under 90 dBA. Class 5 is for the loudest environments, 105 dBA and above. Higher class means more noise reduction needed.
So you match the class to the noise level. What about temporary versus permanent hearing shifts, TTS and PTS?
TTS is temporary threshold shift. That's when your hearing feels muffled after loud noise, like leaving a concert, but it recovers. PTS is permanent threshold shift. That's irreversible damage to the inner ear, usually from repeated loud noise exposure over time, or sometimes one extremely loud event.
So repeated TTS can eventually lead to PTS.
That's the danger, yes. Those
Yeah.
temporary shifts are warning signs.
And what causes hearing loss? Is it always noise?
Not always. We split it into sensorineural and conductive. Sensorineural is damage to the inner ear hair cells or the auditory nerve. Noise is a big cause, but also aging presbycusis, some medications, head injury, infections, Meniere's disease.
Okay.
And interestingly, some workplace chemicals can also cause sensorineural loss, things like toluene, styrene, lead, mercury, arsenic, ototoxicity.
Chemicals too. Wow. And conductive loss.
Conductive loss is when sound waves are blocked from reaching the inner ear. Could be earwax buildup, fluid in the middle ear like glue ear, perforated eardrum, infection, or a foreign object, basically a mechanical problem.
So damage versus blockage. We've got some audiogram examples here. Can you point out a couple of patterns?
Sure. Look at the axis frequency across the bottom, low pitch to high pitch. Hearing level down the side, softer sounds to the top. The O is right ear. X is left ear, air conduction.
Okay.
Presbycusis, age-related loss, typically shows hearing dropping off mainly in the higher frequencies, often similarly in both ears. Noise-induced loss often has a characteristic notch or dip around 4,000 hertz.
Whoa, that 4K notch.
Yeah. Conductive loss, like the glue ear example, will show a gap between the air conduction thresholds, O and X, and the bone conduction thresholds, often shown with brackets, meaning sound travels better through bone than air. Mixed loss shows features of both.
Seeing the graphs helps visualize it. What about those tuning fork tests, Rin and Weber?
Quick bedside tests. Rin compares air conduction, fork near ear canal, to bone conduction, fork on bone behind ear. Normally, air is louder, lasts longer. If bone is equal or better, suggests a problem. Weber puts the vibrating fork on the forehead midline. Ask where they hear it louder. In conductive loss, it sounds louder in the bad ear. In sensorineural loss, it sounds louder in the good ear.
Clever. Helps differentiate. And workplace hearing tests. What's required in NSW?
Baseline audiogram within 3 months of starting noise-exposed work. Then repeat testing at least every 2 years. Needs to be done by a competent person following the standard ASNZS 2069.4.
Regular checks. Is there compensation if hearing loss does occur?
In NSW, yes, if it reaches a certain level. Generally, you need at least 20.4% binaural hearing loss assessed based on the audiogram. But for some high-risk jobs like police, paramedics, firefighters, coal miners, the threshold is lower, only 6%.
Different thresholds for different risks. Makes sense. Okay, moving to respiratory protection, the masks. What about the filters inside them? P1, P2, P3.
Those letters and numbers tell you what the filter protects against. P1 is for larger mechanically generated particles like basic dusts from sanding wood bigger than 1 micron.
Okay, basic dust.
P2 filters offer more protection. They get smaller mechanical particles and thermally generated ones like welding fumes. They're also used for some biological particles like viruses or bacteria and silica dust.
So P2 is a step up, covers fumes and smaller stuff.
Right. P3 gives the highest level of particulate filtration, used for highly toxic dusts like beryllium or radioactive particles, or when you just need maximum protection.
P1, P2, P3, increasing protection. And the types of respirators themselves, there's a whole range.
Yeah, from basic disposable filtering face pieces, often called dust masks, but proper ones are rated P1 or P2.
Right.
To reusable elastomeric half masks that cover nose and mouth, or full face piece masks that protect the eyes, too. Then you get powered air purifying respirators, PPRs, with a battery pack and fan-pushing filtered air in.
Makes breathing easier.
Yes, and often gives a better seal.
Mm-hmm.
Then there's supplied air respirators connected by hose to a clean air source. And top level is SCBA self-contained breathing apparatus, like firefighters wear, with their own air tank, for immediately dangerous atmospheres.
Quite the spectrum. How do you ensure they actually fit properly, the fit factor?
Fit testing is absolutely crucial. A respirator only works if it seals to your face. The fit factor, FF, measures that seal. It's the ratio of the concentration outside the mask to the concentration inside during a test.
Higher number is better.
Much better. For a half mask, you typically need a minimum FF of 100. For a full face mask, it's usually 500. Fit testing confirms the specific mask fits that specific person, and they know how to put it on right to achieve that seal.
So no fit test, no guarantee of protection.
Pretty much. It's a vital step.
Okay, let's broaden out to health surveillance programs overall. What are the general steps involved?
A good program is systematic. First, identify the hazards. What are people exposed to?
Step 1.
Then, identify the population at risk. Which workers or groups of workers? Then, plan the program, what tests are needed, how often. Based on regulations and risk,
Plan it out.
get baseline health data before exposure starts. Then, monitor regularly. Have a system to collect and manage the data, communicate results clearly to workers.
What if results are abnormal?
Need a clear action plan for that, further tests, removal from exposure, workplace changes, and always follow legal requirements. Finally, evaluate the program. Is it working? Is it effective?
A continuous cycle of monitoring and improvement. Let's look at some NSW examples. Isocyanates first. Where do workers encounter those?
Isocyanates are used a lot in making polyurethanes, foams, paints, adhesives. So manufacturing these products or using them, especially spray painting, like in car body shops. TDI and MDI are common ones.
Okay. And the health surveillance?
In NSW, typically an initial medical exam within 6 weeks of starting, then regular follow-ups, maybe 6 monthly or annually. For spray painters, often more frequent lung function tests early on baseline, 6 weeks, 12 weeks, then yearly.
What's in the exam?
Usually a respiratory questionnaire looking for asthma-like symptoms, a skin check, and spirometry lung function tests. Control is key to good ventilation, spray booths, training, hygiene, and proper PPE. Often PPRs or supplied air for spraying. Sometimes biological monitoring too, like checking urine for metabolites.
Okay, thorough approach. Now, lead. We know it's bad news. What's the surveillance protocol in NSW?
Very strict. Before starting lead work, medical exam, baseline blood lead level, and maybe baseline spirometry if there's dust fume inhalation risk.
And during work?
Regular blood lead tests. How often depends on the level and the worker's sex reproductive status.
Oh, different for men and women.
Yes, the action levels are lower for women of childbearing capacity due to risk to a fetus. For males and non-fecund females, under 10 GDL means testing every 6 months. 10 to just under 20 is every 3 months. 20 or higher is every 6 weeks. Over 30 means removal from lead work.
And for fecund females?
Even tighter. Under 5 GDL is testing every 3 months. 5 to just under 10 is every 6 weeks. Over 10 means removal from lead work immediately.
Very low thresholds for removal, especially for women. What signs or symptoms are they looking for?
And lead can affect multiple systems. Neurologically, fatigue, irritability, concentration problems, headache, gastro, abdominal pain, constipation, nausea. Hematologically, it interferes with making hemoglobin for red blood cells.
Anemia?
Yeah, often a microcytic hypochromic anemia, small, pale red cells. Yeah. You might see changes like increased ALA in urine, increased zinc protoporphyrin ZPP in blood, and maybe basophilic stippling on a blood film.
Key metabolic clues. You mentioned surveillance for other nasties too, briefly.
Sure. Cadmium exposure, maybe from batteries or plating monitor urine for beta-2 microglobulin. An early kidney damage marker. Hexavalent chromium, a carcinogen in plating, welding maybe urine chromium and beta-2 microglobulin. Manganese, in mining, welding neurological checks are important. Nickel, often in stainless steel welding spirometry. Skin checks, end-of-shift urine nickel.
Lots of specific tests.
Welding fumes generally complex mix, no single TWA, but monitor nickel chromium for stainless steel. PAH is from coal tar, soot urine 1-hydroxypyrene. Benzene, a solvent urine SPMA. Organophosphate pesticides measure cholinesterase enzyme activity, looking for a drop from baseline. A significant drop triggers action. Symptoms for OPs, SLDGE, and muscle acronyms help remember them.
SLDGE and muscle.
Right.
Right. So specific biomarkers for many exposures. Now, that difference in lead levels for men and women brings up discrimination issues, doesn't it?
It's a really important point.
Ugh.
Historically, women were often just excluded from lead work. But that's discriminatory under laws like the Sex Discrimination Act. And it's not really effective public health either.
Why not?
Because we now know paternal lead exposure can also harm reproduction. The focus should be on controlling exposure for everyone to safe levels, not blanket exclusions based on gender. It's about managing risk universally.
Makes sense. Treat everyone's health as important. Okay, let's talk spirometry again, interpreting those results. How do you figure out normal obstruction restriction?
Key numbers are FEV1 forced expiratory volume in 1 second, FVC forced vital capacity, and the ratio FEV1-FVC. You compare these to predicted values based on age, height, sex, ethnicity, specifically looking at the lower limit of normal, or LLN.
Okay, LLN is the cutoff.
First, look at the FEV1-FVC ratio. If it's below the LLN, that suggests obstruction airflow limitation.
Like asthma or COPD.
Right. Now, if the ratio is low, and the FVC itself is also below its LLN, that could be a mixed pattern, both obstruction and restriction.
Okay.
If the ratio is normal, above LLN, but the FVC is low, below LLN, that points towards restriction-reduced lung volume, like in fibrosis.
Lungs can't hold as much air.
Exactly. And if both the ratio and FVC are above the LLN, it's generally considered normal. The flow volume loop graph Also gives visual clues, characteristic shapes for obstruction, restriction, or even problems in the upper airways. Plus, looking at the spirometry tracing helps judge test quality, good effort, any coughs.
So numbers, ratios, and shapes all play a part. What about workplace ventilation? Key for controlling airborne stuff. What are the main parts?
A typical local exhaust ventilation system has 5 main parts.
Yeah.
1, the inlet or hood, designed to capture the contaminant near where it's produced.
Capture at source.
2, the ducting, to carry the contaminated air away. 3, an air cleaner or filter, to remove the contaminant from the air.
Clean the air.
4, the fan, which provides the airflow to move the air through the system. And 5, the outlet or discharge point, where the cleaned air, or sometimes filtered contaminated air, is released, usually outside.
Hood, ducts, filter, fan, outlet. Got it. Essential piece of engineering control. Let's switch to radiation. Non-ionizing first. What falls into that category?
Non-ionizing covers a range. Extremely low frequency, ELF, from power lines, electrical gear. Radio frequency, RF, radio, microwaves, cell phones, can cause heating at high levels. Infrared IR from heat sources can cause burns. Visible light glare, eye strain.
And UV?
Ultraviolet radiation's a big one. From the sun, welding, tanning beds. IARC classifies it as a group 1 carcinogen, definitely causes cancer. UVAH is skin, damages DNA. UVB causes sunburn, main skin cancer driver. UVC also linked. Outdoor workers have significant risk. And then there are lasers, intense light beams, classified 1 to 4 based on hazard level.
So UV and high-power lasers are the main health concerns there.
Generally, yes, for non-ionizing. How do we control these?
Usual hierarchy. Elimination, substitution if possible. Engineering controls like shielding for RF or lasers, interlocks on lasers. For UV, think UPF clothing ultraviolet protection factor. UPF ratings on clothes, right?
Administrative control scheduling work to avoid peak UV, limiting exposure time, safety procedures for lasers, having a laser safety officer for high-power ones, and PPE appropriate clothing, wide brim hats, sunglasses meeting the standard, ASNZS 167, sunscreen, SPF 30+, ASNZS 2604. For lasers, specific eye and skin protection depending on the class.
Layers of protection. What about ionizing radiation? The more energetic kind. Dose limits.
For occupational exposure, the internationally recommended limit is an effective dose of 20 millisieverts MSV per year, averaged over 5 years, and no more than 50 millisV in any 1 year.
20 per year average.
And for the public.
Much lower. 1 millisV per year above background levels.
Big difference. How is it controlled in places like hospitals or industry? Again, the hierarchy. Elimination or substitution if possible. Then engineering controls are key. Shielding, lead, concrete, and distance. Intensity drops rapidly with distance. Administrative controls focus on minimizing time spent near the source and maximizing distance. And finally, PPE, like lead aprons, thyroid shields, leaded glasses, provides personal shielding, but it's the last line of defense. Time, distance, shielding are the big 3 principles.
Time, distance, shielding. Got it. Okay. Chemical safety. Safety data sheets, SDSs, what's their role?
SDSs, or MSDSs as they used to be called, are crucial. They're the main source of detailed info on a chemical product to tell you what it is, who makes it, what the hazards are, health, fire, reactivity.
What else?
First aid measures, how to handle and store it safely, what controls and PPE are needed. Section 8 is vital for that. Physical properties, stability, toxicology info, environmental effects, disposal, transport. It's supposed to be in there. Basically, the instruction manual for working safely with that chemical.
Essential reading before using anything new. You mentioned airborne contaminants come in different forms.
Yeah. Gas like chlorine. Vapor, gaseous form of a liquid solid, like solvent vapor. Aerosol, general term for fine particles suspended in air. Mist, liquid droplets, like from spraying. Fume, very fine solid particles formed from condensation of vapor, usually metals like welding fume. Dust, solid particles from grinding, crushing. Fiber particle longer than it is wide, like asbestos.
Knowing the form helps decide how to sample the air, right?
Exactly. Different methods for different forms. Direct reading instruments give instant results, but maybe less accuracy. Active sampling uses a pump to pull air through a collection medium filter, sorbent tube, which then goes to a lab. Passive sampling uses badges that collect contaminants by diffusion, no pump needed.
And specific methods for gases or dust?
For VOC gases vapors, you might do a quick grab sample or use active sampling with sorbent tubes for personal TWA monitoring or passive badges. For dust, we often measure inhalable dust, gets into nose-mouth, with an IOM sampler, or respirable dust gets deep into lungs, using a cyclone sampler to remove bigger particles first. Asbestos needs special sampling heads and methods for fiber counting.
Different tools for different jobs. We keep coming back to the hierarchy of controls. Can we run through some quick practical examples?
Sure. Top level. Elimination. Example. Stop using a hazardous chemical altogether. Find a different process.
Last option. Next.
Substitution. Replace a noisy machine with a quieter model. Use a less toxic solvent.
Okay, isolation.
Put the noisy machine in a separate soundproof room. Use barriers or enclosures around a hazardous process.
Keep it contained. Engineering.
Install local exhaust ventilation over a welding bench. Use guards on machinery. Wet methods for cutting concrete to suppress dust. Modify the tool or process itself.
Built-in safety. Administrative.
Job rotation to limit exposure time. Safe work procedures and training. Warning signs. Good housekeeping rules. Scheduling noisy work for off-peak times.
Procedures and practices. And last resort.
PPE. Safety glasses, gloves matched to the chemical, hearing protection, respirators. Always use PPE in combination with higher controls if needed, not usually as the only control.
Right. PPE supports the other measures. Now, switching to return-to-work situations. That flags system for barriers. Red, orange, yellow.
Yeah, it's a useful way to think about potential obstacles. Red flags are clinical signs of serious underlying pathology, needs urgent medical attention.
Okay, medical emergencies.
Orange flags point to significant psychological factors or psychiatric symptoms, maybe clinical depression, severe anxiety, PTSD. Might need mental health specialist input.
Mental health barriers.
Yellow flags are psychosocial beliefs, attitudes, emotions, pain behaviors that can hinder recovery. Things like fear avoidance, catastrophizing about pain, belief that work is harmful, low mood, poor coping strategies.
Psychological beliefs and behaviors.
Blue flags are about the worker's perception of the workplace and social context. Feeling unsupported at work, job dissatisfaction, belief that work tasks are too heavy or stressful, conflicts with supervisors or colleagues.
Workplace perception issues.
And black flags are systemic or contextual obstacles, often outside the worker's or employer's direct control. Things like legislation, insurance system delays or disputes, financial problems, lack of modified duties available, family issues.
Broader system problems. So recognizing all these flags helps tailor the return-to-work plan.
Exactly. You need to address the relevant barriers, not just the physical injury or illness.
Makes sense. And just briefly, assessing risk to health overall and basic clinical exams.
Risk assessment follows steps. Define the scope, gather info on the hazard and exposure, assess the level of risk, decide on control actions, record it all, implement the controls, and review regularly.
Systematic process.
Clinical exams in OCHEalth are often targeted. Cervical spine, look, move, special tests like Sperling's, check power, reflexes, sensation in arms, shoulder, look, feel, move, strength, special tests like painful arc, Eptican, Hawkins, Niners for rotator cuff, etc. Hand wrist, look, move, feel, muscle test, sensation, Tindall's Phalen's for carpal tunnel, Finkelstein for Dequer veins, lower back, look, gait, feel, power test, squat, heel, toe, walk, reflexes, sensation, special tests like straight leg raise, slum test. Need to know key nerve patterns, radial, median, ulnar, etc., and screen like the MUR test for hands. Knee ankle, follow similar look, feel, move, special test format. Need to know lower limb myotomes too. Differentiating UMN versus LMN signs is important. Respiratory exam, inspect, hands, face, trachea, lymph nodes, palpate, percuss, auscultate. Systems review helps catch other issues. Remember system MS mnemonic? OSCEs often require specific phrasing, handling difficult scenarios, formulating issues clearly using frameworks like work task environment, TRIAD, or the MXYZ structure for decision-making.
A lot goes into those occupational health assessments. Let's apply some of this. An EBA mechanic. What hazards might they face?
Oh, heaps. Physical, noise, vibrations, slip strips, lifting injuries, electrical shocks, burns, working in awkward spaces.
Chemical. Solvents, degreasers, brake fluid, battery acid, potentially lead from old battery sparks, exhaust fumes, CO, particulates, maybe isocyanates from paint sealants, biological, tetanus risk from cuts, maybe others depending on what vehicles they work on, ergonomic, awkward postures, repetitive motions, heavy lifting, psychosocial, time pressure, shift work, dealing with breakdowns. Lead is a specific one to watch, needing surveillance like we discussed.
A real mix. And this ECG showing atrial fibrillation, why is that relevant?
AF is common. It causes an irregular heartbeat. In some jobs, especially safety-critical ones like driving or operating machinery, the symptoms of AF, dizziness, palpitations, or the risk of stroke could make someone unfit or conditionally fit. Need to assess the individual case, control of the AF, and job demands. Recognizing it is the first step. Right. Potential for sudden incapacity. And psychological triage adjustment disorder, PTSD, etc.
Important to have a basic awareness. Work stress can trigger adjustment disorder. Traumatic events can lead to acute stress disorder or PTSD. Depression can impact work significantly. Recognizing these allows for appropriate support or referral to mental health professionals. Early intervention is key.
Crucial area.
Gra-
Glove selection chart. Why so many types?
Because no single glove material protects against everything. Latex is okay for biologicals, but poor for many solvents. Nitrile is better for many oil solvents, but not all chemicals. Butyl rubber, neoprene, Viton, PVC, they all have specific strengths. You must choose the glove based on the specific chemical being handled, referring to manufacturer resistance charts or the SDS. Wrong glove equals exposure.
Match the glove to the chemical. Heat, illness, and zoonotics briefly.
Heat illness ranges from rash cramps, fainting, syncope, to heat exhaustion, heavy sweating, weakness, temp 40 degrees C, and life-threatening heat stroke, temp 40 degrees C, altered mental state, often dry skin. Control with hydration, shade, worker cycles, acclimatization, monitoring WBGT, zoonotics or animal-to-human diseases, Q fever from livestock, flu-like vaccine available, leptospirosis from animal urine and water soil, flu-like to severe Weil's disease, Legionella from contaminated water systems or potting mix, pneumonia. Prevention involves hygiene, PPE, vector control, sometimes vaccination.
Important for outdoor animal workers. We also had notes on MS, ready reckoners, study design, safety management systems, maybe for another time.
Absolutely. Each deserves more detailed discussion. Good to flag their relevance, though.
Definitely. Well, this has been incredibly detailed. We've covered a huge amount.
We really have lots
Yeah.
of ground.
So for you listening, the key things to take away. Occupational and environmental medicine is complex, linking work, environment, and health. Understanding basics like exposure limits, PEL, TWA, how diseases like silicosis and asbestosis develop, and the importance of controls ventilation, PPE like respirators, and hearing protection is vital.
And those health surveillance programs, managing risk proactively, they're absolutely crucial for prevention.
It really highlights how interconnected everything is.
It really does.
Which leads us to our final thought for you. Thinking about this intricate connection, what are the emerging or maybe hidden occupational hazards we should be watching out for in the future? Nanomaterials, the mental load of AI in workplaces. What's next on the horizon?
That's a really critical question to keep asking.
We hope this deep dive has given you valuable insights. Explore the concepts, think about your own context. Let us know if there are specific areas you'd like us to tackle next time. Thanks for joining us on this exploration of occupational and environmental medicine.